only 30 minutes and lot to discuss. So very tough. So we'll try to do some justice. What I did is, you know that there are most important breast congress in the world that happens. One is an SABC, San Antonio Breast Congress, which happens every year December. That is equal distribution of clinical, medical, surgical, radiation, and research, and also lab research, translation research. It's one of the best breast congress if anybody want to go or present. And all the papers poster presented there automatically get published in the Cancer Journal as an abstract which are indexed. Second one is a St. Gallen. This happens alternate year. Even though it is named as St. Gallens, it happens all over the Europe now. It used to be in St. Gallen, a place about 30 miles from Zurich. I almost attended all of them. It is only early breast cancer. So that is the beauty. So you don't scratch your head on LABC, metastatic breast cancer, and full flooded with medical oncology. Because the moment you are in LABC, MBC, little surgery and everything is medical onco. It's one of the best EBC. All the EBC guidelines come. The beauty of this is at the end of the day, last full day conference is 100 experts sitting there, and there is a voting by audience and them. It is captured and it gets published in Annals of Surgery in the next issue as a special article. If you just download that article and read, the whole guidelines change, and NCCN immediately adopts it. So what I have done is I have taken these particular things from this particular St. Gallens, because that's now the gospel truth for early breast cancer. So I'll try to address some issues in the given time I have. I bring warm regards from my institution where I have moved recently, which is 28 cancer hospitals across the globe. So the whole treatment now in early breast cancer is minimum effective treatment and tailoring the therapy towards each patient. Precision treatment is the motto of this Congress in early breast cancer. So I have actually full surgeons flooded here, except Kajal Shah, who is a senior medical oncologist. I'm missing an imaging specialist. Maybe I'll liberally use the help of them. Okay. So there is no radiation oncologist in this. So I have Uttam, who is from Sita Devi Hospital, my very close colleague, active member in breast field, ABSI from Jaipur. Sarika Lambai, surgical oncologist from SDMH, Jaipur. Ashwin is a very senior surgical oncologist from Bangalore Aster Institute of Oncology. He was the immediate past honorary secretary of ABSI. Kapil Dev, consultant surgical oncologist from HCG Hospital, Jaipur. Dr. Nitin, Associate Professor Surgical Onco, Sri Ram Cancer Specialty Hospital, Super Specialty in Jaipur. And so welcome all of you. So first to my panelists, since we are not doing LABC, so what is the definition of early breast cancer? From each panelist from this side, Uttam. So what do you mean by early breast cancer? Because we have a mixed crowd, radiation, medical, students, everybody. What do you mean by early breast cancer for them, EBC?
So it is T1 or T2N1. That's it.
And T1, T2N1 disease.
I do not differ in the opinion. It is same T1, T2, okay. Small tumors, mobile.
So stage 2 also includes T2, N1, M0. So T1, T2, N0, N1.
Yes.
So Kajal, you believe yes, we are right? Ashwin, anything? If that is an early breast cancer, none of them require any adjuvant treatment because they're early breast cancer. So then the concept of Fisher hypothesis, any cancer cell which has a potential to have a metastatic access to the blood to throw a micrometastasis and systemic disease is not early, because breast cancer, even stage 1, is not a local disease. That's what he moved from Halsted. So all those definition, even though HSCC says is wrong. The definition as per Abulov, EBC is defined as 10 to the power of 5 cancer cells or less than 10 mm invasive. 10 mm, N0, is the only true early breast cancer which doesn't need any further treatment after surgery. They have no malignant potential to throw micrometastasis nor to systemically metastasize. This is the only group less than 10 millimeter invasive cancer, even if it is HER2 positive. St. Gallen consensus says no anti-HER2 therapy. For a change, some patient is away from the clutches of medical oncologist. So I understand HSCC, but truly, if you open the Abulov textbook of medical onco, this is the only true early breast cancer. Early means it cannot throw. But I agree with my panelists. But the HSCC 9, for the convenience sake, divides stage 1, 2A, 2B as early breast cancer, even though node positive is clubbed. And we all know that the moment it is node positive, forget about believing they are early. Even we are a little bit worried operating upfront. Even though they're amenable for best conservation with good oncoplasty at presentation, ultrasound axilla proved node positive, we prefer, unless they're luminally, to go to medical onco and come. So it's an irony, but it's very important to know what is true and not. So this is what it is. So I would put this question to Uttam. So this is a lady who is a premenopausal lady. She's 40 year, lump in the right breast 2 into 2.5, skin intact, clinically N0, asymptomatic, who came with us. Can you summarize to all the audience how should be an approach when we have such a case in our clinic?
All right. So the basics of medicine remains the same. A very good history needs to be taken. And clinical examination should have a good triple examination assessment of this patient. And that includes a clinical examination, radiological, and then histopathological assessment.
Good. So we can summarize it as a triple assessment to be applied. Good clinical examination of the breast, axilla, supraclavicular, bilateral. Then an imaging, premenopausal, a sono mammogram, postmenopausal, both X-ray mammogram and ultrasound. And then not an FNAC, but an image-guided core biopsy and histopathology, then to take it forward by IHC4. Is everybody agrees with you? Yeah. So this is very important message. Goal number 1. Even if it is a fibroadenoma, you think it is benign, even if you think it's a written malignancy, please don't do that. It could be phylloids, it could be DCIS. So, and never do FNAC. If finances is not a problem, please do image-guided, ultrasound-guided. But having said that, in India, very difficult. You can do a freehand core, but core biopsy, not an FNAC. Image guided is preferred, but expensive. If you have a ultrasound within you, or you have a very good rapport with the imaging, the current guideline is even in a palpable lump, there could be a necrosis, non-necrosis, fibrocystic area in the periphery. This is what we should do. Triple assessment, clinical examination.
Here,
yeah, please go ahead.
So we should do mammography, sonomammography first, and then do biopsy. That will be better. Sequencing of the.
Why not the other way around? Why not ultrasound first? She's a premenopausal lady, dense breast, mammogram, may mask everything.
And that's true. Then if we have facility of tomography, that will be better off in that situation.
Invariably, usually when we send it down, they would do both one after the other and they give a common report. I always say without an ultrasound adding, because the most important thing is what appears to be clinically N0. Ultrasound high frequency probe axilla imaging is very important, which people don't do. If you do, as per the SOUNDS trial, there are criteria defined in ultrasound of axilla. If they are suspicious, scoring them, and if you prove they are positive, you don't have to do sentinel node if you believe in not doing sentinel node. So that's why ultrasound axilla is important. So never send for memo alone, please do both and take a report. So guideline.
Just before you go ahead, the statement you said that a true cut biopsy should always be done under ultrasound guidance. If you have a good repo, if cost is not the constraint, I think now in the current scenario, cost comes nowhere in cancer management. Especially, I'll talk about Rajasthan, wherein in government hospitals also, all investigations are absolutely free of cost.
Super.
So everything should be done under image guidance only.
Because the reason is it is found image guided, the core has the highest chance of getting diagnosis first time. And another thing, if you read a new NCCN guideline for low energy resource, middle energy, delay in arriving at diagnosis is a bad prognostic marker. We say that we have a economically challenged country, so I'll do FNA. You do FNA, multiple FNA, negative, fibrocystic, then you put a knife. Then you lose an option of breast conservation. Then delay of 1 month before definitive surgery comes. Then you don't do image guided core. Report says we don't know in situ, not malignancy, not no adequate tissue for IHC. Again delay. So 1 month delay in presentation to operation in itself is a bad prognostic marker. You patient loses 2 to 3 years. So delay should not be done. So if you don't want to delay, core and image guided gets you quick diagnosis on the same week patient has come.
So country where you can use a true cut biopsy needle 20 times and you can do 10 ultrasounds for fibroadenosis diagnosis. I think cost is not a
PET scan sometimes.
Oh,
People
yes.
get PET scan for fibroadenoma and come. So don't do that, okay? So this is what is something which is very, very important. There's an algorithm Just because we have memotome, contrast mammogram, vacuum VAP, please don't misuse them. There is a specific indication for them. Please use a simple examine, take history, both breast, core, IHC4, memo, straight away, you're not done any harm to that patient. Okay. So now this patient had a core biopsy, ductal cell carcinoma, ER positive, PR positive, HER2 negative. As per ultrasound of axilla, it is sound trial says none, no suspicious note, so N0, clinically N0. Now we have a ductal cell carcinoma, T2, N0, M0, luminal B variety. So what should be the standard metastatic workup? We will take from surgeon Ashwin, and then we'll ask medical oncologist. So what should be the metastatic survey? Bone scan, to be done, not done, CT scan, PET scan, MRI breast. We have so many things.
If the triple assessment shows that it's early breast cancer, I would do the basic lab test, then ultrasound abdomen, pelvis. If there's any discrepancy in any of them, then I would add a bone scan, CT scan, and PET scan. Otherwise, I wouldn't insist.
No, so you would say no metastatic survey required in early breast cancer, which is true.
No,
but where did ultrasound abdomen pelvis come from?
No, that's
why you want to do ultrasound abdomen? In an early breast cancer, no metastatic survey. So
right.
What does ultrasound do? If you are suspicious of liver, then you should do CT scan. So
Right.
is ultrasound part in the recommendation?
when
Early breast cancer?
I would follow ultrasound abdomen pelvis, CBC, LFT, and a chest X-ray. That's
So
what I
no
said.
metastatic survey in early. Does our medical oncologist agree, Kajal?
Yeah, in our institute in early breast cancer with ERPR positive, we do the chest X-ray, ultrasound, blood reports, and if there is a suspicious of any malignancy in chest X-ray or ultrasound, we advise the PET CT.
Why PET CT? Which guideline says PET CT in breast cancer? NCCN, ASCO, ESMO. Which guideline has included PET scan in breast cancer?
It is an operable breast cancer, so to
No, what I'm telling is you told PET scan, but where did PET scan come? Even if it is LABC today, PET scan is not recommended. Even in metastatic breast cancer, PET scan is not recommended. So where did PET scan come for early breast? Does anybody has anything to add?
So like bone scan when to be done when patient has symptoms of bone pains or alkaline phosphatase is raised, then only. And clinically you find any bump on the bones, like any swelling, then you can do it. Yes. CT scan when your chest X-ray findings are unequivocal, you want to confirm it, then only. PET scan when all your investigation are unequal, then only you have equivocal, then you have to only do a PET CT scan.
It is very
Doctor,
important. Yes, please.
I normally do an ultrasound of the abdomen and ask the patient if she's ever had an ultrasound, because this is probably the first time ever that the patient is having an ultrasound of the abdomen. So that is just a sort of a screening program for maybe other diseases. But if the patient has never had an ultrasound, I would do an ultrasound.
Okay, that is immaterial. That is any patient coming is a different. But for cancer, the golden rule is stage 1, stage 2, no metastatic survey to be done. Number 1, if he is asymptomatic. Number 2, there is no role of PET scan in any stage of the breast cancer as a standard. It's very important to understand. PET scan is not a replacement for a thorough bone survey evaluation, even in LABC. The reason is PET scan has a very low CT scan, which is inferior than a conventional CT. So, and it is very poor in identifying osteoblastic and osteosclerotic metastasis in breast. In breast, we have 50% osteolytic, 50% osteoblastic. So, PET scan doesn't show. That is why NCCN clearly says a negative PET scan in a woman doesn't rule out bone scan. If you have a suspicious bone lesion or if you have an LABC where bone has to be evaluated, it is a F18 PET bone scan, but not a normal FDG PET scan. So PET scan, no, please don't do that. I know that, in one cost we can screen top to bottom, but it is a low quality CT, inferior than a good CT. And bone evaluation is inferior in PET, you have to still repeat bone scan. So that's why even in LABC, CT, chest, abdomen and bone scan and not PET is recommended in PET. Okay. So it's very important that we don't do any of them. But however, I'll take this point, in an early premenopausal woman presenting, you may have a hereditary breast ovarian syndrome. Sometime ultrasound for adnexal evaluation is done in an young woman, because a woman premenopausal presenting with early breast cancer is an indication for hereditary breast ovarian cancer evaluation. but not a standard. So this is what all the studies says. No metastatic survey because the yield even in stage 2 is less than 5%. So 95% of women undergoing all, and in this modern era of oligometastasis systemic, even stage 4 we don't preclude a definitive curative treatment. Stage 4 leave 5 years.
No, Somashekhar, there's a difference here when there was a talk yesterday about lung cancer and they were saying in stage 1.
In which one?
Lung cancer.
Yeah, lung is a different issue. Lung is completely different.
In less than 2 centimeter lesions also.
No.
And
See,
here we
lung
don't.
cancer, the guideline is very clear. If somebody has an adenocarcinoma operable T1B N0M0, there is a chance of lung metastasis, and treating brain metastasis, treating that will still be cured.
But the chance will be less than 2%.
Yeah, but the thing is, the oligometastasis can be cured there. That's why NCCN enlists MRI brain in a adenocarcinoma lung 1B and above, whose surgery is the first modality of treatment to do MRI, because the management there is different, but here it is different. So PET scan also not recommended. Remember this. Second, do you want to do, so this is very important. Don't ever be under a misconception. Negative PET scan means bone is negative. No, bone scan is superior to that. Now, she's a young lady, okay, T2, N0, M0, amenable for breast conservation. We have read that, no, dense breast, mammogram not good, multicentricity not found, MRI better. Do we want to do MRI? Nitin?
Well,
Breast.
for tomography.
Because we had a beautiful talk.
Tomography rather than MRI scan.
So, Ashwin, do you
MRI
want
is
to
very sensitive. It will increase the morbidity, it will increase the biopsy rates and more of mastectomy rates. And that.
So, MRI.
No, I wouldn't insist on every patient. So if the patient wants a BCS and if the ultrasound is showing patchy response, and if I'm not sure if I'll get,
No,
then
response,
maybe
we are not yet come to chemo.
Yes,
We
sir.
might operate upfront. So, MRI
I
is a
don't
premenopausal breast.
Otherwise, I wouldn't insist.
Okay.
Oh, yes. An MRI if the patient is asking for breast conservation
Yeah.
surgery.
Patient asking, okay. Patient, no problem. Yeah. Do you want to do MRI?
If we are doing BCS, then yes.
So, how many in the audience believe in a premenopausal lady? We want to dense breast, we want to do breast conservation. Or the same lady has taken neoadjuvant treatment and she is coming for breast conservation. We have read that no, lobular carcinoma is seen better in MRI. Multicentricity seen better in MRI. Dense breast better seen in MRI. Neoadjuvant chemo you give, whether it is patchy response, scattered response, MRI. DCIS, MRI better. All that. Keeping this in mind. How many you think MRI of the breast is included in standard guidelines to do it?
No.
1. So that is the misnomer. I was just in BC conference 2 days back for last week in Ahmedabad, Breast International Imaging Society. The top 3 MRI specialists of the world, okay, from Scotland and US presented. 4 randomized control trial. Premenopausal breast cancer, MRI done, and breast conservation treatment done based on that, one group. Standard triple assessment ultrasound mammogram done, same treatment done. All the 3 randomized control trial told ipsilateral breast recurrence, margin positivity rate, outcome, overall survival didn't change. Only thing that changed is people who believe and use more MRI, more women lost breast. Mastectomy incidence in the MRI used institution and organization was double. More breasts were lost without any benefit in margin, recurrence, overall survival. This is one of those things our eye sees so beautiful, but science doesn't speak. So that is very important.
So one question about this. What does the histopathology of these females showed? Was that comparable to the histopathology of the patients? They must have lost it because MRI must have shown something which is scattered or multicentric disease or multifocal disease. Was that extrapolating?
It's a very good paper. 14% of the time MRI was very sensitive, not specific. MRI showed lot of things which were interpreted as malignancy, DCIS, when actually it didn't turn out in the final histopathology. Even in those patients where it turned out, it didn't make any difference in the margin positive. See, the final proof of putting in MRI is, if you use an MRI, your margin positivity rates and ipsilateral breast recurrence should change. Overall survival, leave it, because the medical oncology, hormone, chemo will take care. It's unjustified to put it on MRI. For MRI, see, if indeed MRI evaluates the volume better, it shows the disease better. If you're not done MRI, you're under operating, right? So margin positivity and recurrence in the breast should be high, no change. Both are same.
Excuse me, Dr. Chandrasekhar. Yeah, I was also there in the Ahmedabad conference. So yes, I agree with you that means many of the researcher, including me, we have observed that the sensitivity obviously is very high as well as the
Specificity is very low.
specificity. Yeah, that was my research area to find out that how we can use it more efficiently to increase the specificity of that. So regarding that breast conservative surgery, yes, they have the Western population they have, but the thing is that their scenario and our country scenario is very, very different.
No, but
You-
is
we
there any
all know
paper
that.
from India where MRI is
So,
better? No, do we have
yeah.
it?
So
Is
we
there any
have,
randomized control? No.
we have different scenario, the younger population and dense breast, and
But
sometimes
all
it
these
is
three
very
randomized
useful.
control trials which are published
Yeah.
were in premenopausal women predominantly.
Yes.
Because MRI would not be
So-
used in a postmenopausal single lesion, which is no use.
Obviously, sir, it is needed to be a comparative meta-analysis, something kind of that to
Even
show that-
meta-analysis published
Yeah,
last year, even that is negative.
That is really, it is a need of our that we should use that the Western population and our population and do the analysis of that.
No, but it is done already. That is surprising. The meta-analysis done in premenopausal woman also didn't show anything. So it's very important to understand, please don't spend money on MRI unnecessarily if you don't know what to look. There are
Dr. Som,
specific indication of MRI.
Dr. Som, just for residents, the role of MRI in early breast cancer in premenopausal women is only when you have used this imaging as in during your triple assessment.
Yeah, that's
Only then,
different
if
issue.
you have
No.
used, yeah.
Yeah, see,
Otherwise, no.
remember, I agree with you. If you do MRI, response assessment looks better, dense breast evaluation MRI better, DCIS better volume of disease, it looks good, but unfortunately, one of those things, the proof of pudding is, if you show how I made a cake and when you eat it, it is not what it is. So the proof of pudding is in eating it. So the proof of MRI evaluation based treatment is it should improve margin negativity rates when we operate and local recurrence, but it has not done. And there are three randomized control trial. So it is one of those conditions. Please don't misuse MRI. There are specific indication today as per NCCN. Number one, hereditary breast ovarian cancer syndrome, BRCA1, BRCA2. You must do MRI. MUO axilla adenocarcinoma. There is a axillary lymph node. Core is adeno. Memo ultrasound PET kit, whatever you have done is negative. MRI should be done. 76% of the time it will identify T1 in the breast. Number two. Number three, if you have done a breast conservation, radiation is over. On the follow-up, you don't know the scar, fibrosis versus recurrence. It is equivocal. MRI should be done. A woman had a breast augmentin surgery or has got a silicone process in the breast, and now you're evaluating for breast cancer, you must do. These are the only 5 level 1 evidence as per ASCO, EGSO, and ESMO and NCCN. MRI has to be done. Rest is investigational as of today, even though it's a good modality. So we'll wait for this. So this is all I have written. Very poor sensitivity. So it has not altered local recurrence treatment. So don't misuse it. There are specific indication you can use it. There are all the papers. I put all these papers. I can't waste. Rightfully, when last year in St. Helens, 100 experts in the world, including 40 breast imaging specialists, who and who in the field of MRI breast, when they asked should MRI be routine in a premenopausal woman to decide on BCS, 90% told no. The own expert who have written all the papers. So remember this, okay? This is very important. Now I have very little time. Uttam, now we are dealing with a premenopausal lady. Can you tell the audience when would you consider doing a BRCA testing? When, what is the current recommendation? Absolutely, you must recommend those women.
So I won't tell the current recommendation. I would tell what I am doing.
Okay.
So I'm doing for any premenopausal female, I'm sending her for BRCA testing.
Good, very
That's
good.
it.
Any other point from all other panelists?
Family history of young breast cancer, we have breast ovarian cancer and rectal cancer, prostatic cancer, pancreatic cancer. They come in the family genome BRCA1
Good.
and 2 should be considered for the same.
Anything extra in addition to that?
The same.
Same
points
thing.
are said.
Okay, Ashwin, anything more?
Say.
Kajal, anything more?
Male breast cancer.
Okay. So remember, now it is available. I will summarize with the want of time. Any premenopausal breast cancer with unilateral breast cancer, any woman with bilateral breast cancer at presentation, any woman with triple negative breast cancer at presentation, history of double breast cancer in the family, first degree relative, breast and endometrium or breast and ovary, in the family, you have to refer now. Now the guideline is like that. There is germline mutation done from the blood. It would also show what is happening to patient and for family member screening. From the block, you ask BRCA, that is somatic, that helps only that patient. Family will not be helpful. And then we have HRR and HRD. HRD is better, which is done both somatic and germline, both from blood and tissue. So if you do germline mutation, you will pick up 10 to 15% hereditary breast cancer. If you do somatic from the block of core biopsy, 5% more. If you do HRD, 40% you will pick up. In India, germline is typically 10 to 15,000 now. Somatic, another 15,000, 30,000 combo. HRD, only 2 company in India is doing, and they charge between 60,000 to 1 lakh. The Myriad from US is the best, which is 2.9 lakh. If you want to do one HRD, but it costs 1 lakh in India, usme treatment khatam. So the way we do, even though it is not ideal, is we do germline because very easy. Then you do somatic, negative, then you ask patient, are you affordable? So remember this, you must do in all these patients. It matters a lot. Number one, for that woman, you know, opposite breast, ovary, what is happening. For the family members, if there is germline, you can do genetic counseling and make management treatment for them. And now, as per the Olympia trial, even in stage 2, you have to give PARP inhibitor after treatment for that woman. So many things changes. So please keep all this in mind for the patient. So these are the things which we said. Now, is BRCA contraindication? Woman is BRCA1, BRCA2 positive. Is it contraindication for breast conservation?
I think yes. I'll say yes.
Oh, very good. I'm happy you're in panel. Anybody? Because, you know, they say that except God, everybody has to give evidence. Which trial has told BRCA woman, if you do breast conservation, they die more than woman who has mastectomy, and they have more recurrence in the breast than which study? Because you told us, are you aware of any study which says in BRCA woman, you do breast conservation instead of mastectomy, their outcome is inferior? Any study you're aware? Because it's a general myth people have. BRCA means double mastectomy. No need to remove both breasts. Remember, it is one of the treatment, not the only treatment. Yes, it's a different issue. You have to remove both ovaries. I'm happy I brought this point. Number one, BCS is possible even in BRCA. Unilateral breast conservation without contralateral mastectomy not required. It is not one of the. There are 3 options. Double mastectomy with both laparoscopic salpingo-oophorectomy, or just doing laparoscopic salpingo-oophorectomy unilateral. All are same, as long as you keep the woman on observation. Surveillance is an option. Double mastectomy is an option. Risk reduction, raloxifene, tamoxifen is an option. Even in a common woman, even in a woman with breast cancer index, it is there. The reason is none of these are contraindication. Young age, and then lupus, BRCA1, BRCA2, contralateral chest irradiation, node positive, high grade, triple negative, retroviral, nipple involved, none of them are contraindication. Remember this. In this era, the only contraindication is multicentric tumor, not able to achieve R0 with a good cosmesis. Diffuse malignant looking calcification all over the breast are the only contraindication. There is no true contraindication in era of oncoplasty, because Uttam, we know now we do extreme oncoplasties. As long as you can remove that multifocal disease with a negative margin, give a viable cosmetic outcome, none of them are contraindication, including central areola. We can do a Grisoti flap. Yes, Uttam?
To summarize, it is, if you're not compromising the oncological outcome, anything is possible, it should be done.
So now in this era, almost there is no contraindication for breast conservation except 1 or 2 small indication, which is very, very important. So this is what St. Gallen told. I will tell you, this is something not many people know that. 2 scenarios. A patient with breast cancer today, while working up, is BRCA positive. Or a normal lady on a screening is BRCA positive. In that woman, if you do double mastectomy or you just keep on surveillance, there is no survival benefit in either arm. This is a beautiful paper. Please read the JCO 2019. Double mastectomy in a woman with BRCA, 20-year survival benefit is 1%. How many of you know that? BRCA means double mastectomy. I know all medical onco, radiation, my colleague, BRCA patient, a double mastectomy. So please think about it. This trial clearly showed, as long as the woman is ready to be on observation, but don't remove ovary. Ovary is a hidden organ, no screening available for CA ovary. You have to do, there is a survival benefit. But double mastectomy, 20-year survival benefit is 1%. Please don't unnecessarily knock off them this particular area. The other issue is, when is a patient in early breast cancer, even though they are operable and breast conservation is possible, we want to send them to neoadjuvant chemo. So all surgeon, Ashwin, when do you think, even though they are early breast cancer, amenable for breast conservation at presentation, still I want them to go to medical onco for neoadjuvant treatment? When?
If first it is the lump is too big and the breast is small, and I want to
So you can't
downstage
achieve a
clinically,
cosmetically
yes.
viable lump
Yes.
excision with negative margin,
Yes.
number one. Then
Second thing is pathologically, if anything greater than 2 centimeters, HER2 positive and triple negative,
so
they say
HER2
survival
positive
benefit.
more than 2. Good.
Yes.
Then
And triple negative,
negative.
if more than 2 centimeters. These are the 3 reasons. I would
anybody
take.
has anything? See, this is very important to understand. In this era, don't put the knife first. Even though they are amenable for breast conservation at presentation, except luminal EA, all HER2 new positive, triple negative, more than 2 centimeter, N0 maybe, should go to neoadjuvant chemo. The reason is, if they're HER2 new positive, you do chemo, residual cancer burden is poor, then switching over to TDM1 has survival benefit as per Catherine trial. If they're triple negative, you're given chemo, all chemo should be finished. You operate and then you actually subject them for surgery if there is a residual cancer burden, RCB index 2 and 3, giving 6 months of oral capecitabine tablet as survival as per Createx trial. Okay, so don't operate, please, except luminal A patient who don't respond to chemo, and that is the only point. So this is called as RCB index. If your report after neoadjuvant chemo comes from a pathologist with RCB, don't accept that. Send it back, call them and tell them there is an RCB index. This is a calculator available online. Tell your pathologist to put this calculation. Check. It will say RCB index 1.271. After chemo, when you do surgery, if RCB is 0.1, they have same survival as complete pathological response. RCB 2 and 3, if they are HER2 new positive, switch over from trastuzumab to TDM1. And if they are triple negative, add 6 months of capsule. This is available in my hospital since 4 years. Without this report, I don't receive them. It's available. It's called a calculator. Please read this particular issue. I will end in a minute. Kajal, since she's very young, she wants to have one more child. Is there any way we can keep her ovary and fertility preserved? Do you want to advise anything to her during giving chemo?
We have a misovulation and that is sparing.
Okay. Now, one is they go to IRT center and they can cryofreeze the eggs, number one. During chemo, do you want to give any medication so that the ovaries function can be preserved? Any trial? You want to give POEMS trial? So when would you recommend GnRH analog during the chemo for that woman to maintain her ovary?
If patient are receiving a neoadjuvant chemotherapy, and then with neoadjuvant chemotherapy, we give GnRH analog to maintain that ovarian cycles.
So remember, if you have a premenopausal breast woman, number one, BRCA1, BRCA2, HBOC panel full you have to do. Number two, you need to make sure that if she needs a cryofreezing of her eggs has to be done. Then during chemo, give LHRH analogs so that their ovary are preserved. Goserelin, 2 years during chemo and post is definitely known to do this. I have to end this part. Is sentinel node contraindicated in a patient who goes for neoadjuvant chemo?
No.
Okay. This is very important to understand that if you clip the axilla node, if it is positive, and you do a clipped targeted axillary clearance, SLNB before chemo or after chemo is not contraindicated. Suppose a patient comes to luminal EA, tumor is very big. Chemo doesn't act much in luminal EA. Is there any role of neoadjuvant hormone therapy to downsize and operate? Kajal?
In early breast cancer, generally there is no role of neoadjuvant endocrine.
With GnRH analog and AI, can we give luminal EA to reduce that size by 6 months and do breast conservation?
We actually, after surgery, we actually do the oncotype DX and mama print in early hormone positive breast cancer to find out the effectiveness of the chemotherapy. We can give only adjuvant endocrine therapy in early hormone positive breast cancer. But I think a neoadjuvant endocrine therapy at present is no role.
There are 2 papers published in SABC that if their luminal EA size is big and at presentation breast conservation is not possible, then doing a core biopsy KS67 and endopredict, and if it is low score, putting them on GnRH analog with AI and operating at 6 months also is beneficial. And tamoxifen, these are 2 trials. We underestimate. With tamoxifen alone, 52% reduction happens. With letrozole GnRH analog in premenopausal women, 61%. This is equivalent to chemo response, remember. So luminal A don't respond to chemo much. Don't underestimate the only problem with harmonic is 6 months you have to wait, unlike chemo where in 3rd, 4 months you can actually go back and do. This is what I told. You need to keep a clip if you want to send the chemo. And also you need to clip the axillary node, targeted axillary clearance you can actually do. So as very rightly told my colleagues, sentinel node is not contraindicated even if you want to do this. So with the want of time, I'm very sorry, I may have to end up. This is 30 minutes is impossible for me to do the panel, but I'll conclude this question, nipple sparing. The whole thing about nipple sparing is if you preserve the nipple, it was recommended you have to give 1 dose of radiation to the nipple areola complex. And it could cause actually, unfortunately, necrosis of the nipple areola and the sensation could have been lost. But now less than 2 centimeter tumor away from the central quadrant, nipple sparing mastectomy on select basis you can do, but it is not level 1, very close to level 2A. So it is not contraindicated in a premenopausal. This is one of the premenopausal lady, you can see nipple area sparing I have done, and I have put a implant, and then this patient could actually undergo. So I will conclude. Core biopsy is mandatory, both in LABC, early breast cancer. MRI, not high level evidence, select cases. PET scan, please don't do, it is not recommended. Neoadjuvant hormone therapy in luminal A to downsize for 6 months, recommended. Please do gene profiling if you want to avoid chemo, oncotype, endopredict, memopredict, nothing to pick. Triple negative, HER2 new, more than 2 centimeter. Please send for neoadjuvant even though surgery is possible. And if you give chemo, entire chemo should be finished, then only operate. Don't be in a hurry. Sandwich therapy, please don't do, because RCB index is important. At the end of all the chemo, if there is a residual cancer burden 0, 1, no change in adjuvant, 0, RCB index 2 and 3 you have to change over. That's very, very important. Arjuna hormone therapy is now for 7 to 8 years, and so no pessimism. Neoadjuvant chemo, even in operable subsurge, this 40% increases breast conservation, 40% positive axillite downsizes, 60% margin positivity rate it reduces. So 3 de-escalation happens. More breast preserved, less axillary lymph node clearance required under complication, less chance of margin positivity, no ink in the BCT. So this all benefits. So this one place, don't put the knife, use your medical oncologist. Thank you very much. I thank my panelists and audience for participation. Thanks.
Thank you.
If there are any 1 or 2 questions we can take, I overshot already by 5 minutes. Anybody, any students or any senior want to make a comment? Good. Now we know what is the definition, above definition of early breast cancer. The trap question. Yes. Mic there? Yeah.
Necessary for every lesion.
Yes.
I would add one more thing, that's the 14G core is much better for the breast. So that is also very, very necessary.
And also if you have a diffuse microcal, then vacuum assisted removing and bracketing of the lesion is very important to remove. That's a lot of topic I couldn't cover, but good point. So please don't be in a hurry to put a knife. Use your imaging, especially breast imaging. Use your medical oncologist more. Don't worry, cancer is not going to go there. Woman will come back to you. And you can do a less surgery, less oncoplasty, better cosmesis, better breast conservation, at same cure rate and no more recurrence rates.
Comparison of different chemotherapy response by mammography precision, which is better.
Unfortunately, this is one of them. Even though it looks glossy, it is not translated. So as of today, conventional mammogram ultrasound clinical examination is the gold standard in breast cancer treatment, even if it is breast conservation. Tomo, then contrast mammogram, MRI looks very good, not yet reached there. So take it on a case-to-case basis.
What is the benefit of using a 14G needle in place of a 16G or 18G?
14G core gives a very, very good sample for the histopathological analysis for the detail, whatever we want. So that is no repetition of that, the low sample in the 16G. So that is why they can give that complete analysis of that. So pathologists also want that 14G sample. It's like they are also very good.
So with my personal experience, this patient, 40 years or less than 40 years, the ductal tissue is quite hard, as I'll say. It is not that easy to pierce it. And a 16 or 18 G needle would be easy to pierce. Anyhow, we take 4 or more than 4 cores. So I think the amount of tissue would be good enough. So for me, it is like.
Thank you very much. And also we learned today that BRCA means please don't refer them to knock off both. BRCA means please do germline, somatic, HRD, do a good genetic counseling. Don't rush to remove both the breasts. Thanks.
Thank you, sir. And thank you all panelists for the wonderful panel discussion. Now,